Welcome back to Conversations with Us. We continue to discuss occupational therapy related topics and the changes that has occurred within the occupational therapy practice. This is Mapule Masamola Ralihika. Please stay tuned. Good day. Welcome to Conversations with Us, a space where we discuss everything occupational therapy related. Next on our show is Mr. Harry Selala, an occupational therapist who's worked both in South Africa and in the United Kingdom. And I believe Harry has qualified as long as I have. Good day, Harry. Welcome to the show.
Good day, Mapule. Thanks for having me.
Okay, how are you today?
I'm doing great. And your side?
I'm great. I'm doing well, thank you. I see you all PPE'd, but before we get to that, I will let you introduce yourself and tell us more about the space that you work in.
Yeah, as you've already mentioned, my name is Harry Selala, an occupational therapist, working as an independent OT over here in South Africa. Mostly doing locum work over here,
Okay.
and just so that I can have that flexibility. But I've worked in a variety of settings, your medical legal settings, hospital-based, but I'm currently working at a mine sort of setting, whereby we are doing your return to work assessment as well as your general rehabilitation at the workplace.
Okay, so what kind of cases do you get at the mines?
Yeah, basically at the mines we start with your pre-employment screening, whereby we see people who have been shortlisted to start and to work in the mine. So we checking their capabilities. Are they having any functional or physical limitations? We work in a multidisciplinary team with your biokinetist, where we check also your cardiorespiratory capacity to check if they've got the capabilities to perform the work that they've applied for in the mine. But we also
most of the work. Sorry, Harry. Is the most of the work that the assessments you're doing for people who are going underground, right? Or
yeah, we're doing for people going underground, but we're also doing for those working at surface. So what has happened is that the previous OTs have done job analysis for most of the work occupations that are here. So even if it's somebody who's not going underground, they still have to undergo this specific test for their specific occupation. So that's basically it. So it's both underground as well as not underground.
Okay. Okay, interesting. Very interesting aspect of occupational therapy. Yeah. So
Yes.
more about your vocational rehabilitation. So what sort of things do you do in your vocational rehabilitation?
Yeah, obviously, it's people who work in the mines. They either get sick or they get injured in the mine. If they are absent from work for about 14 days, it is a requirement that they must go through occupational therapy as well as biokinetics, so that we can check if they are fit enough to go back to work.
Okay.
So after they've been cleared by the doctors, this I to say, they are now medically fit. They come to us, we take their job analysis, look at the job requirements, and then we take them through the cardiorespiratory assessments that we have here, and then looking into whatever reasons that got them to be off sick as well. We therefore make recommendations whether they are fit to go back to work or they need to be referred further.
Okay.
So we're dealing with a variety of conditions. It could be physical problems, but it could also be cognitive problems whereby we need to see them for a couple of sessions before we can say they need to go back to
Back
work.
to work. Okay, sounds very interesting. Very interesting. So,
Yeah.
now during the COVID-19, has there been a significant change in the way you practice or the way you carry out your assessment, or has it been the same?
Yeah, well, there's significant changes all across because as you can appreciate, a lot of things now are done virtually. And with some of our assessments, it becomes very difficult to actually go into that space of virtual assessment. But we see that now we have less space for our clients to sit, obviously, because of that social distancing.
Yeah.
And we have emphasized on your sanitizing, washing of hands. It's something that was there before, although it was not emphasized as much as we do. We use a lot of stickers or colors so that we can see if people have gone through the screening process. So
Okay.
what happens is that as they walk into our practice, we do a screening whereby we check their temperature, check for symptoms if they have symptoms that they have or not,
Mm-hmm.
before they move to the next stage of assessment. So you're gonna get a green sticker to say that no, you've gone through the screening process, then you can move to the next stage.
Okay.
If you don't pass that, obviously then you have to go through to a process where you're gonna have to be tested for
Oh,
COVID-19.
do you
Uh,
guys see a lot of post-COVID-19 cases yet? Or
yes, yeah,
okay.
yeah, yeah. We've started to see quite a lot of post-COVID-19 cases, and
Mm.
what we see is that they need a few sessions to actually be ready for normal return to work.
Okay.
Because what the disease does, it actually causes a lot of problems in terms of your cardiorespiratory because it's a respiratory illness.
Which
So
is
they
very
struggle
important down when if you're underground.
absolutely if you're underground because you need to have a specific sort of heart rate to be able to sustain the requirements underground.
Okay.
So we see that quite a lot of them need to be seen quite a few times before they can actually go through the return to work uh, process.
Process. Oh, wow. Very, very interesting there. So now, what do you see going forward, occupational therapy wise, let's say in your setting? Do you feel like that's going to be an ongoing thing, or do you feel like there need to be more changes and adaptations in the future? Let's say there's another pandemic rocks up. Has it opened up doors for, more innovation or some sort?
Yeah, well, obviously, having worked in the UK as well, where I saw that the infection control is more stricter than it is over here.
Yeah.
So this pandemic has given us an eye opener this side. If you wanna compare with first world countries, most of them have already had processes in place to deal with infection control. But
Absolutely.
this side, we starting this pandemic has actually put us up to speed as to the importance of infection control.
Mm.
So these changes are things that I see them as a permanent sort of arrangement. Although outside our workspace, they might be relaxed a bit due to the economy, because it might be difficult to sustain the economical demands of the infection control measures outside our workspace.
True.
But if you take different companies or companies that are well-to-do, they will really like to actually keep these arrangements in place, because I think it's quite important that we continue with these processes or these measures to prevent any other pandemic in future or any other infection there is. Because what we've also realized is that the winter season is almost done, and most people have not had your normal flu,
Yes.
which by this time of the season, people would be coming in with your normal flu.
Yeah.
But then the reasons could be that, because people are wearing masks, people are washing their hands, people are keeping a social distance. So in other words, people are more healthier.
So
the
those
infection
measures
control,
that COVID, they're also quite handy with the measures or general measures of other illnesses or other respiratory related illnesses, in other words. That's what you're saying.
of course.
Yeah.
Yes, precisely that.
Okay.
So it's a plus, although it's during something which is quite deadly.
Yeah. Yeah. Oh, thank you so much, Harry. I know you got a very busy schedule where you're working, and you've been really, really helpful. Is there anything else that you want to add to this?
Well, it's the new normal now. We're getting used to it. Yeah, it was difficult in the beginning, but I think it's something that is going to be with us for some time. And we should explore more into virtual assessment as well, especially for your review cases. If
Yeah.
it's somebody that you have already seen and you just want to check how they are, and if there has been any improvement, I believe probably there's no need for them to come into the assessment center. If they do have access to your internet and your smart devices, you could just zoom in and do your session right there and then go into your files and just update. I think it's something that we probably need to explore further.
I think so. I think you're onto something there, and that's really good. Like how we're doing it now, there's no need for us to be with the technology these days. There's no need for us to be physically there. No, I totally agree.
Yeah,
Okay.
Absolutely.
Okay, watch the space, everyone. Thank you, Harry, for joining us again today. And you've been.
It was a pleasure.
Thank you. Okay. Good day, everyone. I'm back again. My name is Mapule Masamolorali Hika. I'm an occupational therapist. Continuing with conversations with us. With us on the line today, we have Lize, an occupational therapist based in South Africa. Hello, Lize.
Hello, Mapule. How are you?
I'm fine, thank you. How are you?
I'm very, very well, thank you.
Okay, thank you so much for joining us for this conversations, which is a space which is OT related. Before I continue, I will let you introduce yourself and tell us more about what you do.
Okay, so hi everyone, I'm Lize Kubannek. I'm an OT practicing in Polokwane. It's in the Limpopo province of South Africa. I have got a general-based OT practice running. That's the advantage of living in a smaller town and city. So I do mostly pediatrics. I'm SI qualified. I do a little bit of NDT and general perceptual and developmental stimulation. I also do medical legal work, some voc rehab, some hand splinting, and then some adult rehabilitation.
So you got loads of experience. How long have you been practicing for?
I qualified from the University of the Free State in 2002. I've been practicing since January 2003.
Oh, wow. A year before you qualified.
Huh.
Wow. Very nice. Okay. During this current COVID-19 pandemic, there's been a significant change in the way people have been practicing. Has your practice been affected much?
Mapule, to be honest with you, Yes and no.
Mm-hmm.
You know, in South Africa, the lockdown was announced end of March. So
Yeah.
we were initially encouraged to go into a 3-week total lockdown, which was then extended. So for that period, my practice was closed completely. So, you know, if you don't work, you don't earn an income. So that was quite stressful and hectic. And then we were closed March, April, and then in May they announced the level 4 lockdown. So the essential services could start rendering services again. So I opened my practice part-time. So I would see a few patients on a Monday, Wednesday, and a Friday. But obviously with the whole social distancing and sanitizing, it became quite an ordeal. You know, especially considering in pediatrics, you use a lot of equipment.
Yeah.
So that was quite a challenge, but it was fascinating, you know, and we made it work. But obviously, your number of clients that you were able to service on a specific day drastically declined.
Yeah.
So we are now on level 3 lockdown. It was introduced in June this year. So slowly but surely things are returning back to normal, for me at least.
Okay.
Yeah.
And then you talked about pediatric patients. Tell me more about the patient's age. Between what ages do they range from?
The patients that I see are from newborns,
Okay.
your premature babies. Those I see mostly in hospital though, and then once they are discharged, I will do some home visits. The babies that I see are mostly your cerebral palsy, your Down syndrome, your autistic children. So the youngest child I've got in therapy at the moment is about 4 months old.
Oh,
And then, like I said, for the children, I also work with teenagers, obviously. So the oldest, I would guess if you call it a child that I'm seeing at the moment, is a grade 11 student. She's 17 years old. And then obviously I've got my adult population as well. Before the lockdown, the oldest patient I was seeing was a psychiatric patient. She was 72 years old.
Oh, wow.
But
it's a wide
gap.
Oh, wow.
Yeah, it's quite a wide range, which is exciting. I enjoyed quite a lot. But obviously those are your population that's at risk for infection with the COVID. So her sessions, unfortunately, we haven't resumed. I've given a program to continue with, and we've had some telephone conversations, which is not ideal.
Yeah.
But the COVID-19 actually turned out to be a blessing in disguise for her. So it worked out quite well.
It worked quite well. And then with the kids, what do you do? Is it mainly, does it range from sensory stimulation to perceptual, cognitive, or is it school related? How does it work?
Yeah, it depends obviously on the child that I'm seeing with. I do contact sessions or groups at a center for autistic children. But in South Africa, our private schools are all closed down, unfortunately. So that hasn't happened since the lockdown was announced initially, which is unfortunate because these kids really can't afford not to have their stimulation. But the problem is there's just no way to maintain social distancing with autistic children and not in a group concept.
Yeah.
So individually, what we've been doing is the way I used to work prior to the lockdown is I would have back-to-back sessions. So my session would be 45 minutes long. And then when the next child arrived, then obviously the previous appointment would end and the next child would start their appointment. But now, in order to quickly decontaminate and wipe down everything, I've lengthened my sessions to an hour.
Okay.
So we'll have a 45-minute session with the child, and then we've implemented drop-off rules where the parents have to arrive at a very specific time. The child will wait in the car. I will go and fetch them, take their fever, do the whole sanitizing, and then escort them into the practice. We'll have the session, and I'll escort them out after their 45 minutes, and then I'll quickly wipe and sanitize everything. And then after 15 minutes, the next child will arrive, and then we'll continue that whole procedure. Oh, wow. I look like a mad scientist initially with my little suit and my mask and my face shield and everything.
You got everything.
And that also has an impact, you can imagine, on your interaction with the child.
Yeah, I know.
Because now there's no connection, isn't it? Especially with your younger children.
No, and we look like
depend a lot. Person is depending on them.
And we OTs depend a lot on the face-to-face interaction. So it must be quite interesting doing all of that. Do you think this is the new norm, or do you think this is just a temporary thing and it will all blow out?
Honestly, I think this is going to take longer to blow over than we anticipate. I think, especially in South Africa, there's been a huge escalation in cases. I mean, 70% of my therapy population has been in isolation throughout this course that we restarted therapy, either because a teacher was infected or a parent was infected. A couple of my kids themselves were tested positive for COVID-19, so then they have to go into isolation for 2 weeks. So that's very disruptive as well. You can imagine if you are working on sensory integration dysfunction, or you are working on school readiness, perceptual training, or whatever, especially now that the face time in our school system is limited. You know, our children with challenges is having a really, really hard time. So their therapy is interrupted. And I think the poor parents are so overburdened because now they are doctor, they are nurse, they are mom, they are playmate, they are teacher, so they have to become therapists as well. So that can be quite a challenge. So we're not getting to everything the way we should.
That could be quite overwhelming for the parents. And that brings me to the next question, like way forward, how do you see OTs adapting or changing to pandemic? Let's say next year or year after a new pandemic comes up, or touch wood, hopefully not, but let's say something unexpected come up. Do you think there'll be a change in the way that we should be thinking as occupational therapists on how we practice?
Yeah, I think it might be inevitable. I think what it also has been really encouraging is to use your clinical reasoning there, because at the end of the day, we're not supposed to do any harm. And I think OTs, if you look at our scope of practice and how well equipped we are, I think can be a very vital role player in how to deal with this, especially considering your leisure and all the free time that people are having now, and maybe also looking at emotional well-being. I think I see a lot of my kids, the parents are just so relieved to get them out of the house for a little bit because they become depressed. So they are so relieved that the OT sessions have resumed, so that they can just have a little bit of time away from their parents, and just to get someone else to interact with them. And most of my children, especially the ones that have not returned to school, are really, really missing their friends, missing that interaction and that social participation. So I think we will probably have to facilitate. You know, I know at a lot of schools here, my nieces go to Petersburg Primary School, and they don't have any playtime. They've got their classes where they have their desks open in between, and then break time, they sit on their little chair, they're allowed to take off their mask and have a sandwich.
Oh my
so
goodness.
I think that's sad. That
is
really,
so sad.
really
And
sad.
you know, for us, the occupational performance areas, should we say, play is one of the most important one within the OT profession. So that's actually quite heartbreaking that
what I've started doing is I've started allocating a little bit of time of my sessions just to work on a little bit of play therapy, just to check how the kids are doing, are they still okay, and then to address any underlying frustration, depression that is manifesting. So I've also been doing a bit of parent counseling on how to maybe get the routine, because I think also because schools are closed, the children sleep until 9 o'clock, 10 o'clock. You know, so the routines are disrupted. They are not eating healthily. They are not getting out doing exercise. So we are going to have to maybe advocate and maybe do a lot of counseling in terms of just maintaining healthy lifestyles, even if it is an isolated environment. So I pray and hope that this is going to pass soon. I don't think that it will. I have been mostly able to return to my normal way of practicing, even if it's with masks and face shields and thermometers. But at least it's possible. You know, I only do one-on-one sessions if I do my afternoon therapy sessions, so social distancing is not an issue.
Okay.
And I've been very privileged. My husband is a paramedic. He owns an ambulance company. So I have my practice decontaminated every week, and touch wood.
Oh, that's perfect.
I haven't destroyed any. Yeah, it helps. It helps to have
Helps
connections.
a lot.
Yeah, so I haven't had any symptoms or any of the kids that got ill here. So it's a relief, because I think that's also a burden that we carry. No, I don't think we'll forgive ourselves if someone gets really sick through something that we do.
Yeah.
So I think that's another consideration, that whatever you do, it has to be in the best interest of the patient that you're treating.
Yeah. Oh,
And
wow.
children don't understand, especially the little ones. They don't want to wear their masks.
No, not all the time, only for 5 minutes.
Yeah, so that has been quite a bit of a challenge. And also, if you have sessions with babies where the caretaker and the mom has to be present, you have to look at how are you going to accommodate that.
Mm.
So, luckily we are good at problem solving, and thinking out of the box.
I know. Yeah, definitely. That's definitely for us. Yeah. Oh, thank you so much. I think that's been so informative. Is there anything else that you want to add that you feel you could share with other OTs out there, especially the SI or OTs that work within the SI industry or pediatric industry?
That's a good question.
Mm.
Maybe if I think about it a little bit, I'd be able to come up with a brilliant answer for you.
Maybe keep going.
But I think what I would maybe just suggest is that a lot of the therapy, instead of doing it hands-on, is to train the caregiver, isn't it? That we used to do when we worked in government, is so that the mom is the one touching the child. So I'm very fortunate. I've got a little 15-month-old of my own.
Oh,
so
wow.
Peter has become my therapy assistant.
Oh, wow.
So if I've got babies who obviously cannot wear masks, and it's not in their best interest, then I would use him, and I would take a little video and demonstrate to the mom, and let her do it side by side with me, so that I can check that she's using the right key points of control or doing what I need her to do. And that has worked. It's not the ideal, but it works. Yeah.
Oh, okay. Oh, that's good. Because some of one of my people I know this side was saying that they're having like virtual therapy, and I think that hasn't worked that well with them, especially with the kids. But what you just said now, and actually that makes even better sense. If you have a small child there and demonstrating it, and then asking the mom to do the same thing, that makes even better sense. Yeah.
Yeah, I know Utamsa has actually presented webinars and given a lot of information about how to do telehealth conferencing and whatever. I haven't personally done it because my personal feeling is that's not OT.
Yeah.
Maybe in a different setting, maybe in psychology, if you've got a more counseling role, if you've got adult patients where you can just maybe collaborate a little bit, follow up on their treatment programs, maybe that's a different thing. But for pediatrics, you need that hands-on.
You do.
You need that face-to-face. So I can't imagine that you're going to provide a quality service over phone, or over computer screen. So it's a difficult thing, and I think a lot of it has changed, isn't it? That we're doing
we have to adapt,
programs, providing the parent with more information, training them to better stimulate their kids at home. But then you have to be sure that the parents will do that, and that they are equipped to. On top of being the teacher and on top of being now the full-time carer, to add the burden of being responsible for this child's therapy, some parents just don't cope. Well, that's what I find. So it's tricky.
It's interesting times in our lives. It's interesting time. We never know. But thank you so much for getting involved in this webinar. We really, really appreciate it. Hopefully, we'll get people out there to be able to recognize the part or the role that we play within the society, because we play a very integral role by looking at the whole, looking at a person holistically, but not just focusing on a person on their own. So I really, really appreciate it, and thank you so much for joining us.
You're welcome. Thank you for having me.
Thank you. Hi everyone, welcome to Conversations with Us. I'm Makulema Samola Ralihika. With us today we have Rikha Wilmot. Rikha is an independent occupational therapist, studied in South Africa, my fellow South African, and practiced both in the private and public sector, both in South Africa and in the UK. I met Rikha in 2005, and she is a wicked hand therapist, but since then, things have changed since then, but she still does practice hand therapy, but she's expanded her OT scope of practice. Before we continue, and before I let you continue, I just have to mention also that Rikha has also done some voluntary work in Mozambique and in India, and of course, so what kind of people I know and what kind of people occupational therapists are. Welcome to the show, Rikha.
Thank you very much for having me, Mapule.
Hi, Rikha. Thanks for joining us.
You're very kind in your description.
No, couldn't have said it better. Anyways, Rikha, in the last, like with the COVID pandemic, it has changed so many ways how we practice. Before we get to how the changes have occurred in your practice, just tell us more about your practice prior to the COVID-19 pandemic.
Okay, right. So basically, most of my career, I've been an independent therapist. I've done locuming, I've done private work, and most of my locuming jobs have been in the NHS, private companies, and social services. So prior to the COVID-19, I was actually doing the Blue Badge assessments. So it was during the time when the Blue Badges actually changed in England, and it included the hidden disabilities. So that was in August of 2019.
Oh, tell us more about the hidden disabilities. What is that? Yeah.
Right, so the hidden disabilities, see, previously with the Blue Badges, it was based on physical disabilities. So if you had a spinal cord injury, or if you had arthritis, things like that, amputees, they were assessed.
Visible.
Yes, visible, physical ones, yeah. So what happened?
Sorry, Rikha, let me stop you there.
Oh, you go for it.
Before, I've just realized that our audience are from different countries. So we got audience from South Africa, America, New Zealand, and Australia. So So I'm just going to briefly let you also explain what Blue Badges are. So I've just realized it might be called different things in different areas.
Yes.
Or different countries. Yeah, we'll talk about the hidden disability in a bit, but just explain to us what Blue Badges are.
Yeah, sure. So Blue Badges in the UK is a special concession that allows people with disabilities to be able to park as close as possible to essential facilities, or for things like being able to go to the shops, being able to go to the bank, going to your GP practice, things like that. So basically, it's a government concession that allows people to be able to park as close as possible to avoid unnecessary walking or limiting the risk of any danger in terms of their mobility to get to their destination.
Okay, so in the all the disability parking signs near the shops.
That's it. That's it. So basically, the Blue Badge entitles you to be able to park in those disabled parking spots. Otherwise, you'd get I think it's £1,000 fine now if you did that.
Oh, wow.
Yeah.
That's a lot of money, a lot of fine there.
Oh, it's a lot of money, but the Blue Badge itself in England only costs like £10.
Oh, wow.
And it entitles you to use your Blue Badge for 3 years.
Oh, wow. Wow.
So it's definitely value for money, because in council parking, so council-owned parking, it's generally tends to be free.
Yeah.
So you can have unlimited parking and it's free. And you can park on double yellow lines. There's certain road markings that people with Blue Badges can actually park on.
Okay.
And private car parks, depending on the owners of the parking, they can decide whether they're going to charge or give a concession. Like most supermarkets are free anyway.
Yeah.
But sometimes tourist attractions, they tend to give you free parking plus a concession on the ticket to enter.
Oh, wow. So it's a really good initiative by the government. Yeah.
It's a brilliant initiative by the government, really. Originally, it used to be called the Orange Badge.
Oh, okay.
It changed over to the Blue Badge when with the European Union.
Okay, interesting. So going back to those ones with the hidden disabilities. You spoke about hidden disabilities. Yeah, tell us, you were saying about hidden disabilities.
Exactly. So as OTs, we know people with different disabilities, for instance, they have different needs. So it's not just the actual act of walking, it's also being able to get from A to B.
They say
so
endurance.
So endurance is one part of it. The other is like, take for instance, somebody with autistic spectrum disorders. They would have sensory overload just from being able to get from A to B. So sometimes a blue badge enables the family to participate in social events, to be part of normal life.
Yeah.
So parking is close to like a shop, the cinema, being able to go to a restaurant, for instance. It alleviates the stress as well as the danger associated with it. So children, I say children, adults as well. So anyone with attention deficit problems, anyone with claustrophobia, people with
even relapsing MS, because 1 minute they're okay and the next, it's a very easy condition to to ignore, because there's such a vast difference in the way the patient presents from when they're not in relapse phase to when they are relapsing.
Exactly. So MS technically would have been under the physical. So under the old system, they probably would have qualified. But with MS, like you said, you can have a different pattern that can look completely normal and walk, and the endurance is really good. But the blue badge is really good in the sense that it takes into consideration how often somebody has a relapse.
Yeah.
We can't predict. With most conditions, you can't predict. But what you can have is a general idea of how the person functions.
Yeah.
Exactly. And then you look at that general idea, and then you're able to decide, well, actually, a blue badge would make that person's life a lot easier.
Okay. Fantastic. So before the COVID, has there been any changes before the COVID and now on how you practice or how you carry out the assessment for the blue badges?
Right. So basically, prior to the COVID pandemic, we used to do things like face-to-face assessments where we would do mobility assessments. So invite somebody into a clinic and actually assess their walking ability. When the new hidden criteria came into play, we had to devise a new way of being able to do this assessment without necessarily calling them into an office. Because if you took, for instance, somebody with autistic spectrum or claustrophobia, inviting them into a clinic for an assessment is really not realistic at all.
Especially wearing masks as well on top of it. So that's not really...
So then when the pandemic started, you basically had to, most of the country, I should say, actually almost all the councils decided not to do any face-to-face assessments. In fact, they put a hold on most assessments, and except for the ones that were the automatic criteria, or for those that were really, really, I wouldn't say serious, because I don't really like using that word, but for somebody whose need for a blue badge was far more urgent. So it cut down the assessments quite a bit. But now with the ban lifting, so to speak, and everyone going back into practice, everybody's had to look at different ways of how you can do these assessments. So again, each council practices differently how they process the blue badge assessments. So in my last post, I created a screening tool which actually worked really, really well, where we did not have to see the person, but based on the points that people would score from the screening tool, you wouldn't necessarily have to have a face-to-face assessment, or you could actually issue a badge without needing any further evidence, so to speak, or further input. So basically, we've reduced the face-to-face need. But currently I'm not doing the blue badges anymore. I've unfortunately, due to my personal circumstances, had to stop that contract that I was in, just for my personal health. So I cut out all face-to-face assessments for a few months, but I've started back at work again, but I'm doing a completely different thing to blue badges now.
Okay, tell us more about it. Tell us more about your current role?
Current job.
Yeah.
Well, the current role that I am in, again, it's as a locum or a contract worker. And I'm doing a community OT post, which is in a council again. So basically, it's going out and doing assessments for people in their homes to see if they need adaptations, aids, or equipment to help them to live as independently as possible.
Mm-hmm.
So we're looking at things like major adaptations for level access showers, through floor lifts, stair lifts, ramps, things like that.
So you're still going to people's homes now, or?
All going into people's homes, except we have to follow the government guidelines in terms of our face-to-face contact. So basically, gloves, aprons, masks, and then we use visors, but the visors are normally used for people who are more vulnerable.
Okay.
So we don't use a visor for every visit that we go out to, but we use a mask for every visit that we go out to.
Okay. Do you see any changes in practice, let's say in social services going forward? Or do you think,
yes,
or even implementing your tool going forward, do you think that will be more long-term?
Well, in terms of the blue badges, okay, let me do the community one first. So the community, in terms of going forward, I think we found that people can actually do more work working from home than they can having to have to go into the office as much.
Okay.
And you can cut down on face-to-face contact with clients because you can gather quite a lot of information over the telephone.
Mm-hmm.
And if your client is tech savvy as well, you could do a Skype call, a WhatsApp call, a Zoom call, or we use Microsoft Teams. So it all depends on the person on the other side. So what we found, you can gather tons of information before you actually go out and do the assessment. So your actual assessment bit is where you're actually looking at mobility, you're looking at transfers. And so yes, it's cut down actual contact quite a bit, quite.
And that means it also minimizes the amount of time you spend at the person's home.
Yes, exactly. Yes. So
safeguarding both you and the person on the other side.
Exactly, because I mean, your average community assessment runs roughly between probably 40 minutes to an hour. Sometimes it can go to 2 hours, depending on how complicated it is. But by virtue of being able to get all the information prior to getting there, assessments now are taking anywhere between 15 minutes and 30, which is really good.
It's really, really good. It's really good.
Yeah.
And yeah, that's really good. And do you do any manual handling?
Well, at the moment, to be fair, I haven't had to do any as yet, but I foresee we are going to have to go in and do them because they were totally reduced in terms of face-to-face contact. You had to with most councils, but when moving and handling, you can't not provide a service. Yeah. Oh, wow. So the job role I'm in right now, we only do basic moving and handling. So there's a specific moving and handling team, and they've still been going out during the lockdown.
And doing the major ones and training carers and so forth.
Exactly.
Okay.
And then going to the blue badge bit, the screening tool I developed was, I'm not tooting my own horn here, but it was actually really, really good. And it was internally audited by the council that I was working in. And what we found was the outcomes were very fair and very consistent. So we weren't getting situations in which you would have, say, 10 approvals and then 5 refusals, and those 5 refusals would actually come back and it would be approved because the decision making was incorrect at that point. Okay. So the screening tool actually eliminated a certain amount of the assessor's biasness, so to speak. So it created a fair and level grounding for making an assessment decision. So in terms of that, I'm actually trying to get the screening tool out there and get people using it, just because I'm quite passionate about the blue badges, in the sense that people who need blue badges deserve those blue badges.
And they should be having them.
Exactly. And people that don't deserve it, and
they should be walking like the rest of us.
Precisely.
Yes.
So unfortunately, in the past, well, it's still going on now, is that different councils adhere to different rules. So some people are approved in one council, but they're actually refused in another council. And I believe, as a profession, especially with occupational therapy, is that our duty is to make sure that people who exactly, the person who deserves it should be getting it.
Yeah.
So I'm pretty passionate about it, and because of this lockdown and my time at home, I've been designing this Blue Badge course to try and educate. Well, I say educate as if I'm such an expert. No, it's to disperse knowledge about the Blue Badge process and how we can, going forward, make it as fair and consistent as possible
throughout the country. Yeah, I think that's a very good initiative, Rikha. And just briefly tell us about where they can find or access your training. I know it's on you'll be on your website soon.
Yeah, to be fair, there's been some changes going on, so I don't even have a website to give you right now, but I will have that in about 2 weeks' time.
Okay.
Yeah, but we'll be advertising in the OT Journal about it, and we'll be able to go forward from there.
Okay, and I mean that's fantastic work. I know now you're just trying to sort out your private OT work so that you can focus more on private OT than public OT work. Just briefly tell us more about your private OT work.
Right. So I've had the drive to want to do private OT for a very, very long time. But being a foreigner in the country, I wanted to learn how therapy and rehab actually happens throughout the country. So I've been fortunate in my career that I've stopped counting now, but the last count was I've worked in 20 counties in the country. Yep. And you know, Paula, you've done, you've been doing the same.
We've been around.
Exactly. Remember the days when we just pack our car and go from one contract to the next.
Yeah. It's a good learning curve. It's a fantastic way of learning different services. I think what you already know as well.
Exactly. It's absolutely brilliant. And I think it's given me a very, very broad experience of what rehab is. If anything, when I first came to the country, I actually took on a post as a hand therapist because in South Africa, I used to work in a workman's comp or an injured on duties unit. So basically, I was splinting people straight out of surgery. That's it. You know, my work was really involved. And I worked in a reasonably close-knit small team. So we had a plastic surgeon who used to do all the surgery. We had a physiotherapist, 2 physio assistants and 1 OT assistant. And our team was from the get-go, we were getting people out there, and we were one of the first teams to use tea tree oil in terms of instead of most of the other antibacterials, antiseptic things out there. And we had a fantastic successful rate in terms of healing, in terms of decrease in terms of infections. So I was really involved with all of that. When I came over here, I was really excited, thinking I was going to be doing hand therapy to that level. Yeah. Unfortunately, I wasn't. If anything, it was all about single use in terms of equipment and tools. And you were very limited time-wise as to what you could provide. So in South Africa, I used to provide a 45-minute treatment session in which it used to be my clients used to come in and they knew their places to go, because we used to have a group treatment and everyone used to sit at their stations and move from one station to another. And it was that social interaction that also helped them in terms of their healing, because it's not just injury, as we know in OT, it's the whole.
It affects the whole picture. It's a holistic view of an individual, like they exactly like to say. Yeah.
So exactly. So we used to have that group treatment session, and then we used to have individual sessions with the physio, with the OT. And it was one-on-one for about 15, 20 minutes. And it was really, really good. In the year that I spent in that contract, I only had 2 failures. And the only reason we had those 2 failures was, one was a gentleman who was an uncontrolled diabetic. So his healing was just not happening, no matter what we were doing, because his diabetes was out of control. And the second person, well, he did not want to heal because he wanted to claim from the insurance. So from his point of view, he was actually going to get more money from the insurance than he would if he tried to go back to work. But other than that, we had a fantastic, fantastic experience with people recovering and going back to work. So like I said, when I
bringing that into your practice here in the UK,
as far as I can. So yes, so the private practice, the reason I'm really passionate about going into it is because in terms of the NHS and community services, you are really limited because you are using taxpayers' money in terms of the service provision. So you're getting the barest minimum. So what I found was I was giving out extra information to my clients, and even when I wasn't in a role. So if I wasn't in a, say for instance, if I wasn't in a neuro role, but I was in a social services post and I was seeing somebody at home and they had a stroke, I would be giving them exercises and telling them, well, do this because this will help with the tone in that arm or with that position. And I found I kept doing that. Well, you can't help yourself because we OTs, we always want to help.
Yeah.
We always want to do something. Yeah, so I thought about it and I thought, you know what, I have a lot of skill to offer. And I just thought, well, private OT is the way to go in terms of that. So yeah, so that's what kicked this off.
Okay, so watch out everyone for Rikha Wilmot. She's a really good therapist. So yeah, so
oh, you're too kind.
No, she is really a good therapist. I'm not just saying that, but just from my experience working with her shortly down south in Turkey, and also just you know, we form part of a mentorship group, me and her, another therapist. So we're discussing cases and the advice that's been given. It's been really, really
yeah. Right back to you too, Mapula. We've got to a certain point in our career now where actually bouncing and sharing ideas is actually the best thing going forward, because that top-down approach to how OT is managed and how it is it's progressing, I think it's very old-fashioned in lots of ways. Whereas doing it this way, I feel empowered, and at the same time, I don't feel belittled in any way.
Yeah.
Because I'm doing it with my equals. Yeah.
Oh, well, thanks again, Rikha, for joining Conversations with us. Yeah, and thanks for coming for the, so hopefully see you soon when we discuss. We'll probably invite you again. We'll discuss your practice in more detail.
Sure.
Okay.
Thank you for having me.
Have a good evening.